Good afternoon, everyone, and it's really a great pleasure to be part of your conference this year, even though this is virtual. And I know most of you have been missing the personal interaction when we do the face-to-face meeting, but I'm sure this shouldn't stop, the pandemic shouldn't stop us to have a conference. And I'm very grateful for the Pituitary Foundation for inviting me and for this live session. So I was asked to do a brief session on acromegaly, and I did ask specifically whether there's anything specific that members would like me to cover, because as you know, even though this is only one disease area, there are loads of things that we can cover. So what I've decided is to cover some of the basic and also look at how we manage acromegaly during this period of pandemic, just to give some people assurance that your current management is still optimal, considering the challenges that we are facing during this COVID-19 pandemic. But before that, I'd like to cover just a brief overview of acromegaly for those of you who were newly diagnosed, or those of you with relatives that are newly diagnosed with this condition. I'm going to go through the process of how we actually assess, and most of you probably have been wondering why there is a significant delay from the point of diagnosis to treatment, because this is one of the conditions where we have to get things right in order to make sure that the outcome for patients or the outcome for who's ever suffering this condition is optimal as well. And we're going to look at some of the options of treatment and how you're going to optimize living beyond treatment as well. Okay. Acromegaly actually is a very old disease, and for those of you who are fan of arts, you would probably seen some of these paintings, and it is believed that depicted in these paintings are actually people with acromegaly, because all of these are people who are giants. And even in Greek mythology, you're going to see the picture on the top left-hand side. So this is depicted in Greek mythology, where you have this Greek god with one eye, and that one eye is a depiction of one of the symptoms that patients with acromegaly are suffering, that is a tunnel vision. Yeah, and even in the Bible, there was a potential people in there that was potentially had acromegaly, and you were wondering the story about David and Goliath. So we know that Goliath is a giant, but we've been wondering, how did David manage to defeat Goliath? And again, one of the symptoms of acromegaly, as we know, is that tunnel vision, because of the loss of peripheral vision, is because David was throwing, David threw the stone from the side, so Goliath didn't manage to see the stone coming, and that caused that injury. So again, depicted in several other arts are pictures of people with acromegaly, and again, based on historical evidence and based on evidence from historians, there are loads of people from the past, as old as 600 BC, skeletons, human skeletons of people that are clearly giant. So this is an old disease. But in spite of being an old disease, and in spite of the treatment that has emerged in the last few decades, what we need to be asking ourselves is, has the treatment of this condition change or improve over those years, considering this is not a new disease? It's a very old disease. Have we managed to excel in terms of managing and making sure that patients suffering with these conditions are having an optimal quality of life? And that's what I would like to cover for the rest of the presentation. Again, for those of you who are not that aware of what happens in patients with acromegaly, so you know that when you have an acromegaly, you have a tumor. So this blob in here is a tumor that represents a tumor. One of the hormones that your pituitary gland is producing is growth hormone. If this tumor is producing growth hormone as well, so what will end up is the pituitary gland plus the tumor will release loads of growth hormone. So you will have an excess growth hormone in your body. Some of the growth hormone directly influence our body, like our muscle, our bones, and our fat. But majority of the growth hormone released by the pituitary gland and the tumor actually acts on the liver. And that stimulates the liver to produce IGF-1. This is another hormone. And this IGF-1 is the one that has the influence on most of our body tissues. These are the hormones responsible for supporting muscle growth, bone health, and also influencing sugar metabolism. If you have loads of IGF-1 because you got a tumor producing loads of growth hormone, telling your liver to produce loads of IGF-1, you will end up having a large surge of this hormone in your body. And as a result, you will have these effects, side effects or complications of acromegaly. And some of you who suffer from this condition would have been able to relate on this one, such as regular headache, facial disfigurement or enlargement of some of the prominent facial features, such as enlargement of the nose, enlargement of the lips, and also enlargement of the gaps between your teeth. And those patients with low sex drive, enlargement of the feet, so on and so forth. And this is driven primarily by the excess growth hormone, excess IGF-1. So remember, in adult, we don't grow lengthwise because our bones is close. But because you have excess growth hormone, what the growth hormone and IGF-1 is doing is trying to force your body cells to grow. And because there's no way for the body cells to go lengthwise, your body cells is growing sideways. Hence, you would see enlargement of your fingers, enlargement of your feet, enlargement of your nose. Now, the problem with acromegaly, if it is left untreated, are loads of other associated comorbidities. We know that the estimated incidence of acromegaly is 3 to 4 for every 1 million population. And it is estimated worldwide that there are about 36 to 69 people per million affected by the condition. Mainly affecting middle age, and it's equally affecting men and women. And particularly those who are diagnosed late and those who are not treated, there is a known 10-year reduction in the lifespan. So this is very significant because it's telling us that we really need to do something about first early diagnosis of this condition in order to reduce this reduction in the lifespan. And those patients with active disease as well, we know that the mortality is 2.5 times higher than the general population. So there are loads of things that we need to do in terms of acromegaly: early diagnosis, prompt treatment, particularly those with active disease, and those with persistent disease. We need to make sure that we give them treatment in order to control the active disease. Now, one of the main problems with patients with acromegaly, as some of you probably might be able to relate with, is the physical disfigurement. The problem with the changes in physical appearance is some of them will not go back to normal, particularly those patients have been suffering for years and diagnosed quite late. And the primary reason for that is because of the bone changes. The soft tissue changes will subside over time, like the swelling in your, the increase in size or in the amount of your subcutaneous fat. Those will subside over time. What will not improve is the change in the size and the appearance of the bone. And that is very significant because that's the one that gives that disfigurement, that facial disfigurement or other disfigurement in the body. So when we see patients in clinic, we usually are quite blunt or honest to patient because we want to manage patient expectation. That when we see a significant facial disfigurement, we will tell the patient some of them will become softer over time, but it might not go back to where it was prior to you having that condition 20 or 30 years ago. And that's very, very important because we cannot change the changes in the bone, but the changes in the soft tissue, such as the fat, the muscle, and the connective tissue, those will improve over time. Now, this one is a very, very interesting study. And what this study looked at is those patients who presented during the early 1980s with acromegaly, wherein we don't have much treatment options yet, as we have right now. Do those patients who presented during those early years present differently now compared to those patients who are presenting during this modern era? So these are the patients during the early 80s who presented with acromegaly. And these are the conditions and the associated problem they presented with. So during the early 1980s, patients with acromegaly also presented with hypertension, a large number of them, 37% of them. A quarter of them presented with problem with carpal tunnel syndrome or problem of pain in the wrist, osteoarthritis, diabetes mellitus, goiter, polyps, and skin tags. And then this Reed and her colleagues look at what is a typical presentation of those patients presenting now in the modern age. And what you can look at is there's not much difference. Those patients who presented during the early 1980s and compared to those patients who are presenting now are complaining of almost exactly the same issue. They're complaining of hypertension, they're complaining of carpal tunnel, they're complaining of osteoarthritis. And what is the implication of that? We haven't really improved much in terms of diagnosis probably. Why are we waiting for these patients to be complaining and going repeatedly to the GP about hypertension, about carpal tunnel without looking at acromegaly as a potential diagnosis? So most of our patients is still diagnosed quite late, despite the fact that the current patients that we're seeing now have the same problem as those patients presented many, many years ago. And there's several reasons why the diagnosis is quite late, and I'm going to show you later on. As you know, that the main cause of acromegaly is a tumor to the pituitary gland. There's a tiny, tiny small amount of patients with acromegaly due to tumor that is found somewhere else in the body. And that's very, very rare. And that's quite difficult as well to manage because it's very difficult to find where those tumors are if in case they're not in the pituitary gland. But 95% of the cases, patients with acromegaly will likely have a tumor in the pituitary gland. Okay? So the question is why there is a significant delay in diagnosis. In this particular study, published in 2019, the mean years of diagnosing women particularly diagnosed quite late, according to one of these studies, about 6 years compared to 3 years in men. But generally, the diagnosis is delayed by around 3 to 5 years. That's an average delayed in diagnosis before the actual diagnosis is actually made. And there are several reasons for that. One, there's a very slow pace of the onset. So the disease progresses very slowly. When someone presents to the GP with regular headache, your GP will not think of acromegaly straight away because there are loads of other potential diagnoses. Is it something to do with the brain? Is this a cancer of the brain? Is this a normal tension headache? Is this a migraine headache? So there are loads of things that your GP can think of. So acromegaly will not come as first in the list of potential diagnoses. And the symptoms are very slow in progression because majority of the patients I've seen in my clinic were just telling me, I thought it was just because of me getting older. Like for example, joint pains. As you get older, you know people do get joint pains and low sex drive. And people will say, oh, I thought I'm just getting older because I'm 60 now. I'm not that bothered about low sex drive. So the progression is very slow, unlike other diseases where it is instant and constant progression. Again, another reason is because there is lack of specificity. Other patients will have facial feature typical of acromegaly. Some patients don't have the physical feature except for very high IGF-1 or growth hormone in the blood test or sign of diabetes, but there's no physical changes. So there's no one clear, distinct feature that we can apply to everyone. Some patients present with different symptoms, just headache alone without physical changes. Some patients have clear physical changes that we can make the diagnosis quite clear. And those are some of the reasons why the diagnosis is quite late. Unlike, for example, measles, if a child presents with rash typical of measles, we can make the diagnosis straight away because we know what measles or chickenpox rashes looks like. In acromegaly, patients present with different sorts of different presentations. Now, how do we diagnose that? Again, just a brief overview on how we diagnose. In clinic, our first approach is IGF-1. We don't look at the growth hormone, and I'm sure some of you might be asking why we don't measure the growth hormone in clinic. It's because the growth hormone has a very short half-life. And the growth hormone is also released in pulsatile motion, and it is released the most when we're sleeping. So when we check your growth hormone during the day when you attend the clinic and it is low, it doesn't mean that you don't have acromegaly. It's just probably because we didn't time it right when the tumor is releasing the growth hormone. Because the tumor releases growth hormone in pulsatile and the pituitary gland also releases it in pulses. What we want and what is the most accurate way of looking at whether you got problem with your growth hormone in the body is the IGF-1. So this is the hormone released by the liver following stimulation by the growth hormone. And it usually mirrors how much growth hormone you got in your body. So what does that mean is if your IGF-1 is high, it's likely because you have high growth hormone in your body. And the IGF-1 is more stable when you check it in the blood compared to growth hormone. So that's what we check in IGF-1. So if you got a high IGF-1 and you got some symptoms that are potentially pointing towards acromegaly, then we need to confirm the diagnosis by what we call oral glucose tolerance test. And some of you might be familiar or have had that test where you were given a very high sugary drink, and then you had a blood sample taken every 30 minutes. And that is a diagnostic and confirmatory test. And what we looked at is when you're given a very sugary drink, the normal pituitary gland will stop producing growth hormone. But the tumor will not respond to sugary drink because it has a mind of its own, and it will continue to release growth hormone despite the high sugar load. So what we normally see is after 3 hours or 2 hours of you drinking that sugary drink and taking your blood samples, if you don't have a tumor, your growth hormone will go below 1 microgram per liter. If your growth hormone is above 1 microgram, that means there's a tumor that is producing growth hormone independently that didn't respond to sugary load. Again, different centers have different cutoff. In our center in Birmingham, because we have quite a sensitive assay, our cutoff is much lower. It should suppress below 0.4. If it is higher than 0.4, then patients get acromegaly. So in a snapshot, this is the main way on how we diagnose patients. A suspicion that you potentially have acromegaly because of symptoms that you described in clinic, including some physical features, and then initial investigation showed that you have IGF-1. Once we have those two information, clinical suspicion plus high IGF-1, we will then proceed with a confirmatory test called oral glucose tolerance test. And after that, we will send you for a scan, primarily of the brain, of the pituitary gland, to check whether there's a tumor in the pituitary gland. Once we have that diagnosis and we confirm that patient indeed have acromegaly, then treatment is very, very important. As I mentioned to you, if we delay the treatment, there are loads of comorbidities and other associated health problems that could result for patient from not treating patients promptly. Currently, these are our treatment options. The first choice is always surgery. And transmural surgery is the most common approach. So very rare now that the surgeon will open the brain and navigate to the pituitary glands. You have a very, very unique approach wherein a drill is inserted into the nose, and then a camera with a flexible tube is inserted in the nose to navigate through the pituitary gland and locate where the tumor is. So transmural surgery is always the first choice because surgery is the only treatment that will remove the tumor. What we want is to remove the tumor as much as possible and in whole if the surgeon can do that. If surgery is not appropriate, then we have medical treatment. And the good thing we have is we have an arsenal now of medical therapies available to treat acromegaly or to control the disease. So some of you are probably on the monthly injection. They're called somatostatin analog. Some of you are probably on tablet. Those with very, very mild disease are on dopamine agonists such as cabergoline or bromocriptine. And some of you are probably on daily injection called PegBiosimones. And if the first two fails, then we have radiotherapy. And again, we have two choices, either conventional or stereotactic radiotherapy, such as gamma knife. The first, as I mentioned, is always surgery, because this is the only one that will cure the disease. It's the only one that will remove potentially the tumor. But the issue we have right now during the pandemic is there's a shift in how we manage patients because of the potential risk of coronavirus infection. And what you're finding right now for those patients with visual compromise, those with significant problem with vision, the first choice is still surgery because we cannot risk the patient losing their vision. But we will always explain to the patient that we're in the middle of the pandemic and there's a potential risk that if they're admitted in the hospital, there's this chance that they can get coronavirus infection. So we need to get the patient involved in that decision-making, whether they want to go ahead with the surgery. But those patients without significant deterioration in vision, we shift then the choice into medical therapy first. So though surgery is still the first option, but because there's no significant deterioration in vision, particularly I'm speaking about how we do that in our center, we then put our patients into medical therapy. And this is the first time we've been doing that. In our center, we're quite good, and patients with acromegaly, we will push to surgery straight away. And because of the risk of coronavirus, we have to change our tactic and look at what's the safest option for our patient. So most of our patients now, without significant deterioration, will put them temporarily on medical therapy, primarily the somatostatin analog. And hopefully in the next few months, once we reopen the service, most of those patients will go for surgery once we reopen the service. So we have a categorization that we introduce in our trust where we categorize the patient according to priority. From priority 1, those life-threatening conditions that need surgery. Priority 2, those patients who will not survive within 1 month if they then have surgery. Priority 3, surgery that needs to be done within 3 months. And these are the patients with significant problem with the vision are on category 3. The rest are put in category 4, that the surgery could be done within the next 6 to 12 months. So that's a shift that we've done because of the pandemic, and we have to adjust to that because the risk of patient getting coronavirus is higher if we admit them to the hospital because we want them to have a surgery. If we can control the disease with medical therapy whilst waiting for the right time, then that's ultimately the best choice for the patient. In a normal condition, medical therapy are quite good, and usually this is prescribed for patients who are not a good candidate for surgery. For example, those patients with multiple problems, serious heart problem that they will likely not survive surgery if they go for surgery. So we need to control the disease by giving medical therapy. And again, as I mentioned to you earlier, during this time of pandemic, because of the delay in surgery, we're using medical therapy as a first line for patients without significant visual problem. Okay. So the goal of medical therapy is multifaceted. So the medical therapy, particularly the somatostatin analog, can also control the tumor. It will not make the tumor disappear though. Yeah, it can control the tumor. It can control the growth hormone because by shrinking the tumor hopefully will not also release too much growth hormone. They bind to the tumor itself to prevent the tumor from releasing growth hormone. Because the growth hormone goes down with the medical therapy, symptoms will improve. And as we improve the symptoms and improve and reduce the exposure of the body to growth hormone, and we can manage some of the comorbidities, such as patients not developing diabetes, patients not gaining too much weight. And hopefully, by giving them prompt treatment and making that the therapy that we're giving are optimized, we can extend their survival as well. Now, in terms of medical therapy, there are 2 main groups of drugs that we're giving. For those patients with mild disease, meaning those without much symptoms and the growth hormone is only marginally elevated, we can do with cabergoline. They are called dopamine agonists, and this is usually given once, twice, or up to 3 times a week. So this is a tablet that binds directly to the tumor and try to prevent the tumor from releasing too much growth hormone. And to some degree, it can also shrink the tumor. For those patients with moderate and severe disease, we go straight to the injectable medication. And the first choice is usually the somatostatin analog, such as sandostatin ALR or lanreotide. Those of you who are on this medication, you will be able to relate. This is given every 4 weeks. And if you're well controlled, we can extend it to every 6 weeks. And some of you probably, very few of you, would probably on the daily injection called PegBiosimones. I'll discuss that in a bit later on in more detail. Okay. So how do somatostatin analog work? And for those of you who are wondering, how do they control growth hormone? So somatostatin analog binds directly to the tumor there. So the tumor have receptors. So when those receptors bind to the somatostatin analog, that's a signal to the tumor, hopefully not to release growth hormone. And when the somatostatin analog is effective, there will be less growth hormone released in the body. There will be less growth hormone telling the liver to produce IGF-1. As a result, there will be less IGF-1 that is released from the liver. And again, as I mentioned here, there are different choices. So octreotide is the sandostatin, lanreotide is the somatulin autogel, and we also have pasireotide, which we don't use that much in the UK because of the restrictions we have, primarily because of the potential side effects. So this diagram at the bottom, if you can see this, imagine this is the tumor, okay? the tumors have what we call somatostatin receptors. So just to simplify that, what does that mean? If you imagine these different colors receptors, these are the doors that will enable the growth hormone to be released into the circulation from the tumor. So what your somatostatin analog, your sandostatin and ALR does, they block this receptor. So they bind to the receptor so that the receptor doesn't then release the growth hormone. The octreotide and lanreotide binds to receptor 2. Pasireotide binds to receptor 5 and 2 mainly. Some of you might be wondering, I've been on this drug for years, but my IGF-1 is still a bit high. Why is that? Because some tumors have more receptor 3, 4, or 1, where the current drug we have available are not that effective in blocking. But majority of the patient with acromegaly, most of the tumor expresses or have somatostatin 2 and 5. Therefore, most of the drug that we use are effective. For those of you who tried somatostatin analog before and you had to stop because they're not working, it's probably because the tumor have loads of 3 and 4 and 5, 1, 3, and 4, where these drugs will not be as effective if your tumor have more 2s and 5s. And there's no way really of you knowing whether your tumor's got more 2 and 5. These are some of the things that will tell us whether the medical treatment will work well depending on your tumor characteristics. Now, talking about somatostatin analog, as I mentioned to you, it can normalize the IGF-1 in up to 35% of the patients. It can shrink the tumor in around 50% of the patient. But again, the effectivity depends on whether your tumor has loads of ST2, somatostatin receptor 2, because that's where it binds to. If your tumor's got more of receptor 3, 4, and 1, unlikely they're gonna work that well if your tumor has more 2. And for those of you who've been on treatments, you are familiar with the potential side effects of somatostatin analog. The most common is abdominal cramps and diarrhea. For dopamine agonists, it's not as effective as somatostatin analog. That's why it's only indicated in patients with mild disease. So it can normalize the IGF-1 in 30% of the cases. This is only for very, very mild disease. And again, the symptoms, as you know, are abdominal problem, nausea and vomiting, and fatigue. There is another drug, and I was asked to cover this briefly, and that's what we call PegBiosimones. So PegBiosimones works different from somatostatin analog. I mentioned to you earlier, somatostatin analog binds directly to the tumor. If for some reason you've been on somatostatin analog for several months, a year, and it's not making your growth hormone go down, your IGF-1 remains high, there could be several reasons. One of them is because your tumor is expressing different somatostatin receptors, mainly 1, 3, 4, or 5, that the somatostatin analog will not be effective against. Or it might be that your tumor is just resistant to somatostatin analog. We can't leave the patient who can't have surgery without treatment. Another thing that we can target is the liver. So we can target the liver by asking the liver not to produce too much IGF-1. Even though the pituitary gland is releasing too much growth hormone, we can prevent the liver from producing too much IGF-1. And that medication is PegBiosimones. So PegBiosimones targets the liver and it blocks the liver receptor from releasing IGF-1. As a result, there will be improvement in symptoms for patients who are not responsive to somatostatin analog. Okay. There is a strict criteria on who would qualify for PegBiosimones treatment, and this is given by NHS England. For those patients with still acromegaly despite initial treatment such as surgery or surgery following medical therapy with somatostatin analog, and they still remain with active disease. Or those patients that who cannot have surgery, so we can then apply for funding for PegBiosimones. So again, this is not an automatic choice because there is strict criteria on who would qualify for these treatments. Okay, there are contraindications, of course, for any medication, and for PegBiosimones, those patients with severe heart problem and severe liver problem could not have this medication. Now, the common side effects is almost similar to somatostatin analog, the headache, abdominal pain, and joint and muscle pains. And one of the side effects that is not common in somatostatin analog, but common in PegBiosimones, because PegBiosimones is a daily injection, some patients will develop hardening of the fat tissue because they just have to inject every single day. And the fat then develop resistance against that needle, and they become hard and tough. And there are ways of addressing that by rotating the site to different areas in the body. Okay, so we talk about the treatments. I mentioned to you that the first treatment is surgery. And if the surgery is not effective, then we have an arsenal of drugs that we can use, such as somatostatin analog. And if it's still not effective, then the patient can have radiotherapy. Let's say, for example, that you are one of those patients who've been treated successfully and no longer have an active disease. How is it living with acromegaly beyond treatments? This diagram is a very good illustration on how most people who had been treated with following active acromegaly are currently living their life. Okay, so this is quite, it might look complex, but I'm going to simplify it as here. This is what we call the spider graph or spider web. Okay, so this is in a scale of 1 to 100. So the edge there is 100. Okay, so none of us will be functioning 100% all the time. None of us will have a good mental health to the rate of 100% all the time. None of us will be happy 100% of the time. None of us will be will be able to exercise to the best of our ability 100% all the time. Yeah. If you look at this light gray line in here, this is the general population. So generally, people without any health problem functions at around 80% of their maximum capacity. Most of the time, we don't have 80% of the time, we don't have pain. Most of the time, 80% of the time, we'll be able to do what we plan to do during the day. Most of the time, 80% of the time, we are in good mental health. Patients with acromegaly before treatment, this is represented by this broken line at the center. This is their functions and the quality of life. So the physical function before treatment is around 40%. They're usually in pain quite a lot. Their general health is only 40%. Vitality is only around 40 to 30%. But the surprising thing is, after treatment, this is the broken line here at the center, the level of physical function, mental health, doesn't go as near as close as the general population. So meaning, even after treatment, don't be surprised that you won't regain back your quality of life as you had 20 years ago, 30 years ago, when you were in your 20s or when you were in your 30s. This is a proven fact. And what this graph is telling us, you need to adjust your lifestyle accordingly, because there's some aspect of your life that you can manage. Like, for example, we can manage in clinic the complication of acromegaly by monitoring your heart, by monitoring your colon, by doing a bone density scan. We can manage in clinic the complication of treatment so that we're making sure that we're not giving you too much hydrocortisone or too much growth hormone. We're making sure that we assess you for risk of cancer. We make sure that we give you sex hormone if you need to. So this can be addressed in clinic. But what we cannot address in clinic are these aspects here: the psychological, employment problems, social issue, healthy lifestyle, and family issues. You need to adjust it accordingly. Let's talk about healthy lifestyle. During this pandemic, there's so much news about vitamin D and exercise. So make sure that you supplement with vitamin D, and the general recommendation for the general population is take at least 800 to 1,000 units every single day. It will not cost you any harm. We cannot force you to exercise, but COVID-19 is not a reason not to exercise, because you can still walk, you can still run. Because the problem we have sometimes in clinic is, particularly in the pandemic, where we get loads of queries from patients, when patients feeling unwell, feeling depressed, and feeling low, they will contact us and tell us, do I need to adjust my hydrocortisone? Adjusting your hydrocortisone is not always the answer, because too much exposure to hydrocortisone can cause significant problem in the future. You need to think about the other aspect. Are you feeling low and down because you're not doing much activity, and therefore you're not oxygenating your body well? So doing activity will stimulate aerobic activities in your body, increases the consumption of sugar and oxygen in your body, and increases circulation. We have to adjust accordingly, because there's some aspect that we won't be able to address the clinic. Smoking, alcohol are things that you need to think about. Psychological problem. There are very, very few centers with access to psychologists. In Birmingham, even though we're one of the largest centers in the UK, we don't have direct access to psychologists. But you have to recognize when this is impacting your life and contact your GP, and be open to the fact that you might be referred to a psychologist and to a counselor, rather than you waiting for years and years and telling yourself, no, this is my hydrocortisone, this is my medication that needs adjusting. We know in clinic how we adjust that, because we have a biochemical parameter on how we adjust your thyroid hormone, on how we adjust your testosterone, how we adjust your desmopressin. So it's not always your hormone that is causing the problem. It's the long-term impact of you being exposed previously to growth hormone. And there are ways that we can address that outside medical therapies. Okay. Just to close, we talk about how you should be addressing some of the concerns that we cannot address in clinic. During this pandemic, just a reminder, even though you already had your vaccination, still observe the government advice regarding regular hand washing, wearing face covering, and strict social distancing. Remember, for patients who have adrenal insufficiency, those of you on hydrocortisone, you are on vaccine priority group 6. So meaning you should be having your vaccination now. The government has opened the vaccination for group 6 last week. So you should all be having your vaccination now. So you need to tell your GP. If your GP is telling you that you're not on group 6 and you are on hydrocortisone, contact your endocrine team to give you a letter of support that you are on group 6. At the Q in Birmingham, we're sending all our patients who are on hydrocortisone a letter to confirm with their GP they are in group 6. So have your vaccine now. Vaccines are very safe. If it is offered, please take the vaccination. This is our only way out of this lockdown. If you are positive with COVID and you become symptomatic with fever, increase your dose. Just a reminder that sick day rules is different when you have a COVID infection. If you got a positive COVID and you got a temperature, you have to increase immediately your hydrocortisone 20 milligrams every 6 hours, not just double it. 20 milligrams every 6 hours if you got a temperature. If you don't have a temperature and you don't have symptoms and you're positive with COVID, you don't need to do anything. Maintain on your current dose. But if you become symptomatic and unwell, increase 20 milligrams every 6 hours. And again, just to reiterate, those of you who are on hydrocortisone, you are in priority group 6, so you should be offered vaccination regardless of your age. So book your vaccination appointments. So just to summarize, we talk about acromegaly being an old disease. We talk about some of the comorbidities or health-associated issue with acromegaly. We briefly discuss how this is diagnosed in clinic. We talk about the options for treatment, and surgery is still the first choice. And we talk about some of the medical options in terms of the treatments. And lastly, second to the last, we talk about some of the other issues that you as individual affected with the disease can address proactively. And again, we talk about how you should be keeping yourself safe during this pandemic. Thank you very much.
Well, thank you very much, Sherwin. That was brilliant, and it's clearly generated lots of thoughts and questions from everybody. So we have had a few in the chat box, which I can start reading to you now that we've got, and we'll cover a few. So the first question that we have here is from Mike. What proportion of pituitary patients who have acromegaly also have a problem with overproduction of other hormones? My tumour also secretes prolactin.
Okay, so it's not unusual for prolactin to be co-secreted by a growth hormone secreting tumor. So what does that mean? It is a well-known fact that there is a big number of patients with acromegaly wherein the tumor is also secreting prolactin. That's why there are patients, there's a significant number of patients who are combined therapy, somatostatin analog and prolactinoma and cabergoline. And that targets those two hormones that that the tumor is producing. So it's not unusual. There is a significant proportion of patients with combined prolactin secreting tumor and growth hormone secreting tumor. Yeah. So the cabergoline will target particularly the prolactin, and cabergoline can also target the growth hormone to some degree, but they're quite less effective in patients with very severe disease. So they need to have somatostatin analog if the surgery didn't cure them completely. Okay.
Thank you. Okay, the next one, bit of a long one, so just bear with me. What about the patient with normal IGF-1 and acromegaly? Shouldn't the GH and IGF-1 be collected? For example, I had high GH and normal to normal high IGF-1. If I had only IGF-1 tested, I might have waited even longer for my diagnosis.
Very good question. Okay, it's a very good question, and there's no straightforward answer to that. Okay, because if your growth hormone is checked on its own, and if it is high, it doesn't mean that you have growth hormone. If you have acromegaly, because it probably just so happened that during your blood sampling, that it was timed appropriately that your pituitary gland released that growth hormone. Again, this is a very important clinical decision and assessment. So it needs to be a comprehensive assessment. During initial diagnosis, we will always in clinic check both growth hormone and IGF-1 to see whether they match together. So a good endocrine center and a good endocrinologist will always check the random growth hormone and IGF-1 at the first diagnosis. During the first screening, it is acceptable to check both growth hormone and IGF-1. Knowing the limitation in growth hormone, we know that the growth hormone might not tell us much, because if it is low and you get a high IGF-1, the IGF-1 is still far more important in interpreting, provided there is no other condition that can cause high IGF-1, such as kidney problem and diabetes. So in people without those conditions and the IGF-1 is high, it's likely pointing out to a growth hormone problem, but we need a confirmatory disease. And again, you're right. During initial diagnosis, the growth hormone and IGF-1 should be checked in pair. But during monitoring, IGF-1 on its own is enough. For those patients that there is a potential risk for recurrence, because we know that every pituitary tumor, particularly functioning tumor, there is a chance of recurrence in the future. The most important thing with that is regular follow-up in clinic, because the recurrence should be assessed through the clinical manifestation, patients telling us that there are symptoms, and from early screening is very important. It's a screening of your growth hormone axis is very important by checking your IGF-1 and doing oral glucose tolerance test, because that's the only confirmatory test that will tell us whether you have acromegaly or not.
Thank you. Okay, next question. Having had transsphenoidal surgery in 2010, my IGF-1 levels have been stable but slightly elevated, hovering around 40. I'm now 60 years old. What are your thoughts on starting octreotide to reduce this further? Blood pressure is fine, 110/73, fit and otherwise pretty well.
Okay, so if your IGF-1 following surgery is high, provided that that is checked on the same center and not rechecked on other center, because your IGF-1 needs to be monitored in the same center that managing you. You cannot compare the number of your IGF-1 if you had a test from a different center, because different centers have different reference rates and different assays. So very important. So we're talking about here, someone is being treated in one center. After surgery, IGF-1 is high. Even though you don't have symptoms, you still have the biochemical disease. We know that patients with active disease, even though they don't have symptoms, your lifespan will be reduced. Your long-term survival will be reduced. The most important thing in patients with acromegaly is control of the disease. If your IGF-1 is significantly high, you don't have a control of your disease. If your consultant endocrinologist endocrine team is telling you we need to give you medical treatment, you have to actively consider that. Because if you already had significant surgery before and another surgery is not an option, then we have to control that IGF-1, because that high IGF-1 slowly over time will cause problem with your sugar control, with your anxiety and depression, with bones, with your risk of second cancer such as colon cancer, arthritis, so on and so forth. You might not feel it immediately, but over the years they will add up. So the most important thing is control of the disease. And control of the disease can be measured by looking at your IGF-1 and growth hormone levels.
Thank you. Oh, thank you for the questions you're giving, guys. It's really, really helpful for everybody. So next one. I was diagnosed in April 2020 by chance from a brain scan, but it explains symptoms I've had for years. On days when I feel exhausted, is this due to an excess of the hormone being released on that day?
Sorry, I didn't get the first part of the question. What was the first part?
Yeah, no problem. I'll read it again. Okay, I was diagnosed in April 2020 by chance from a brain scan, but it explains symptoms I've had for years. On days when I feel exhausted, is this due to an excess of the hormone being released on that day?
So I take it that whoever answered the question, they haven't had treatment yet. So they still have the disease, or so if you haven't had the treatment yet, and so the exhaustion is definitely as a result of the active disease. And again, the level of exhaustion varies. You're not going to be exhausted all throughout the day, but you know that your level of energy will be low. But the level of exhaustion will depend on, as you mentioned rightly, how much growth hormone your body is releasing or the tumor is releasing. Because the degree of growth hormone will also impact on the degree of the side effects you're having. If your question is you're diagnosed a year ago now, you must have had some sort of treatment. So if you are on some sort of treatment such as medical therapy, you had radiotherapy and you still feel tired, I mentioned to you in my slides, you know, the spider graph. Your physical level of energy will not be 100. It will not be even come close to patient without acromegaly, around 80%. No. Your level of energy will be around 40 to 60%. And it's up to you how you're going to boost that energy level by improving your lifestyle. So what I'm trying to mention, to emphasize in this presentation is you need to adjust your lifestyle to your current condition now. It's not that you're going to limit what you're able to do. You can still do things, but you need to accept that when you were 30, you're able to run a marathon. You will just have to accept now that you probably be able to run a quarter of a marathon. That's still good than accepting that you can't run at all, because that's not acceptable. You still be able to run. And by you pushing yourself, you're improving your stamina and you improve all the other hormones released in your body that are not affected. Yeah. So the level of exhaustion and energy is probably because of the previous exposure to the growth hormone, and we can't do anything about that now. What you can do is prevent that from deteriorating, because it will be a vicious cycle. So we get this a lot in clinic. I feel tired. I can't exercise, so I don't exercise. So you gain weight. You will feel more tired next month because you gain more and more and more weight. So what you need to do is you feel tired now. How am I going to support this? I need to lose a bit of weight in order to improve my stamina. Increasing your hydrocortisone is not the solution. You will gain more weight with that. Hydrocortisone is not a Red Bull. Remember that. Yeah, it's only there to support your sugar, your blood pressure, and your immune system.
Thank you. Next question is just a shorter one. How to monitor people on PegBiosimones?
Good. So patients on PegBiosimones need to be monitored closely during the first 4 to 6 months. In our center, we will review the patient every 4 to 6 weeks when we start them. We don't check the growth hormone. Remember, I show you in the diagram, PegBiosimones doesn't prevent the tumor from producing growth hormone. You still loads of growth hormone there. The PegBiosimones targets the liver. It prevents the liver from reducing IGF-1. So what we monitor is the IGF-1. So we need to monitor IGF-1 every 4 to 6 weeks to make sure that we're giving the right amount of PegBiosimones, and we increase the dose gradually. We start on a low dose of 10 milligrams and gradually increasing into 15, 20 with a maximum dose of 30 every 4 to 6 weeks. There is a slight delay during the pandemic, so we're still able to monitor our patients, but delay around 6 to 8 weekly instead of 4 to 6 weeks. Their sugar need to be monitored as well regularly, because one of the side effects of PegBisimone is high sugar level, which can cause diabetes. So we monitor that closely in patients who are receiving PegBisimone treatment. And because this is a very high cost drug, when you are starting on PegBisimone, there should be a clear system on how you are monitored in clinic, because there's no point in you being started on 10 milligram and left there for 3 months. It will only be effective if we optimize the dose promptly, because it will only work if the IGF-1 is controlled well. If you're on 10 milligram, your growth is still high, it's as bad as you not getting any medications at all. So it is really important when you start PegBisimone that you have a regular follow-up until your dose is optimized.
Brilliant, thank you very much. And I've got another one here. I had acromegaly in my teens 35 years ago, successfully treated and no major issues now. My concern is whether there's anything I should look out for as I age.
I think it's a very good question that applies to everyone as well. So not just those who diagnose at the very early stage during their life. So everyone should be looking for any possible signs of recurrence. But again, there's a balance, because there are some patients who are very focused on the recurrence to the point that it overtakes their life. So every day they wake up, will I have a recurrence of acromegaly? So there should be a balance in that. So what you'll be looking at is again a focus on my earlier presentation, focus on improving your lifestyle. Improve your lifestyle, making sure that you eat healthily, making sure that you exercise regularly, make sure that if you are on regular hormone medications, that you take your hormone medication without over-supplementing yourself. In terms of what to look out for, so look out for the signs that when you were first diagnosed. Are you having more regular headache than previously? Are you feeling more tired than previously? Okay. Are you having problem with the vision? The vision is one of the most important thing that you be looking at. So am I having problem with my vision? Is it deteriorating? So your first approach with the optician. If the optician told you no, that's the time you contact endocrinologist. I've seen my optician already. There's no problem with my vision. Is this related to my previous tumor? So it's about symptoms and looking at whether the symptoms you're having is significantly different from previously. Yeah, and then lifestyle is very important, that we cannot stress enough. And then you need to have a regular follow-up, at least once every 18 to 2 years. We're saying now during the pandemic, 18 months to 2 years, but usually it should be every 12 to 18 months if you have acromegaly, so that we can screen you for any recurrence or screen you for any problem that might be occurring as a result of your condition.
Thank you. Okay, so I think we've just got 1 or 2 more here. Growth hormone level varies throughout the day and age. What cutoff is used in your experience? Could you please advise?
Okay, again, as I mentioned to you earlier, growth hormone alone is not useful in clinical practice. I hardly check patients' growth hormone in clinic, because as I mentioned to you, the growth hormone is released in pulsatile motion every few minutes. So it's not constantly released in the body. Unlike your cortisol, in the morning, there is a high level of cortisol. So if we check the cortisol in the morning, we expect it to be high. If it is low, you have a problem with your cortisol level. The problem with growth hormone is, if we check your growth hormone level and it is low, it doesn't mean that you don't have growth hormone. It's probably because within time, the peak, and we don't know when that peak is, that your pituitary gland will decide to release growth hormone. So the best way, if I want to check your growth hormone, is I'll admit you into the hospital, and whilst you're sleeping, I'm going to be checking your growth hormone every minute. That is too labor intensive. So it's the IGF-1 that we need to be looking at. And the IGF-1 has different ranges according to person's age and sex, and according to the center where it is checked. So the most important thing is, when you are seen in your clinic, ask them for a copy of blood result with the reference ranges, so that you have that with you. So because you cannot compare the range from QE to the range in Coventry. They have different machine, they have different assay. So what you need to be looking at is your IGF-1 should be within that normal range. Okay, so not the growth hormone, but the normal range. So the only time that we check your growth hormone is we do the oral glucose tolerance test. So the cutoff for that, for the QE, is 0.4. meaning if your growth hormone is less than 0.4, you don't have the disease, you don't have acromegaly. If it is above 0.4, potentially you have the disease. In other centers where they use a slightly less sensitive assay, the cutoff is 1. So you need to be checking with the center what is their cutoff.
Thank you. Okay, I think we'll just do one more, if that's okay.
Yeah.
So I've heard of a new treatment called Olitantone. How does this compare with the others you mentioned, especially lanreotide?
Okay, so I think you're mentioning about Olitantone, yeah? So Olitantone is not a new drug, I'm afraid. It is a generic version of somatostatin analog. Okay, so there are generic versions now. So those of you who are taking somatostatin analog, Sandostatin ALR, so the intramuscular injection and the lanreotide, the subcutaneous injection. So the patent for both medication have run out. So meaning there are loads of companies who are jumping into the bandwagon, introducing generic version. So don't be surprised in the next few months if your center or your endocrinologist will be changing your medication to one of these brands. So one has come out already, the Olitantone, which is the generic version of one of the somatostatin analog. Are they as effective? They are effective because they've been approved by MHRA, our regulatory body. So they are generic, so meaning they are cheaper. It doesn't mean that they are less effective. They are exactly the same drug. They are equivalent molecule, and they are as effective as the branded product. So don't be surprised if your endocrinologist will tell you, or if you've seen that the endocrinologist giving you an injection is holding a slightly different looking medication. So it is likely generic, but they should be telling you that you will be switching to a generic version.
Thank you so much to Sherwin for his time today and for giving us that informative presentation and for answering your questions so well. Some really valuable information that you can all take away with you today.